Thank you very much, Nadine. Maybe Natasha, you can join us on the podium in front of the microphone. We have 10 minutes for questions. Please go to the microphone. Microphone at the...
Thank you, Nadine, and Natasha as well, both excellent talks. I guess I kind of have like maybe a contradictory point in regards to the sentence length question. So one of the things that we've been really struggling with in BC is around people who are sort of on the frequent flyer circuit. So they're often on short sentences all the time. They're going in and out of corrections. And so one of the things that we thought was that if we imposed some kind of a sentence length restriction, that we might just continually miss those people. And they're probably the people who are going to miss treatment in the community as well, because we know that those people who are experiencing frequent incarceration are probably less likely to be engaged in care in the community as well. So I guess that's just like a kind of a question, is that a concern that we should be thinking about? Is that if we think about sentence lengths for treatment eligibility in corrections, are we going to exclude some people permanently, or at least for many years, from starting treatment?
Thanks, Sophia. That's a great question, and undoubtedly inherent in having a restriction of incarceration length is missing individuals. And I know some European countries have actually extended individuals' incarceration to ensure that they can actually complete hepatitis C treatment while incarcerated. No joke, no word of a lie. And so I think maybe that's a little extreme. I'm not sure. I'm not sure we've ever asked inmates whether they'd rather stay in prison and complete therapy or be released. But that's something, I don't think we have a solution at this point for the continuously reincarcerated population. But I think that this is an area that we need to work on. And maybe Europe's approach has actually been extremely successful with respect to keeping individuals incarcerated long enough. So it may be something we consider after speaking with the community and ensuring that it is acceptable.
Can I just add to that? So it's a really interesting question, and I think there's two other opportunities. One, I mean, there are obviously ongoing studies of shortened treatment durations down to 4 weeks, and I think that that's an area where there could be particular benefit for it. But back to my point about sort of thinking about the broader issues of drug user health, we know release from incarceration is associated with a highly elevated risk of overdose in the first 2 to 4 weeks post-release. So already this is a critical period for people, especially those who are kind of continually cycling in and out. And I think if we can think broadly about the need to engage those people in care and the continuity of, for example, opiate substitution therapy for them when they're in prison and out, then maybe developing those services alongside with an integrated manner would mean that those individuals could actually be retained in care and complete their hepatitis C treatment in the community, even if they don't have enough time in prison, and therefore you're able to address this period, which we know is really high risk anyway, and so should be of special consideration.
Thank you both for excellent presentations. I'm wondering if there's been a cost-benefit analysis of offering, people who are in substance abuse get packages with syringes. They're usually all orange plungers, so the advantages of a multicolored syringe kit with multicolored syringes would, I've heard lots of stories of people getting infected because, you pick up the wrong syringe. So I'm wondering, after 10 years of asking if there's been a cost-benefit analysis in high-income countries.
That's an interesting question. So if I understood it correctly, it has there been a cost-effectiveness analysis of providing multicolor syringes so there's no confusion about whose syringe is whose? Yeah. So I'm not aware of one. Obviously, we're still in the era of trying to obtain really rigorous evidence in terms of the cost-effectiveness of syringe exchange programs. The effectiveness, I think we're still in the era of trying to obtain more epidemiological evidence in terms of the actual effectiveness of syringe exchange programs, in particular in terms of prevention of hepatitis C. The data are highly heterogeneous. with differences between Western Europe and North America in terms of those effect estimates. But I think we are accumulating those data in terms of the effectiveness in different settings and trying to put, I think, more empirical data in those cost effectiveness evaluations, which before those evaluations maybe from 10 or 20 years ago may have been based on just our assumptions about what providing syringes, the impact that has on a community, whereas now we're actually using empirical data in terms of the association of their risk and hepatitis C and HIV incidence. So I would say that's where we are with the economic evaluations, and I'm not aware of one that has looked specifically at your question about the color coding, but it's a great question.
Hi, yeah, I'm Matt Bond from Halifax, and I guess I got a question for both you, one on jails and one on safe supply stimulant use. And I guess, I'm coming from an experience of being in provincial corrections, watching people share syringes, like one syringe for a whole range, that's a homemade syringe. So I'm just, and it's great that these people are getting treated eventually in provincial institutions. Halifax or Burnside is supposed to be treating people. Until I hear from one of my peers that they actually got treated, I won't believe it. But I'm just wondering, how effective do you think it's going to be to treat if we don't have these harm reduction services as OAT and needle syringe programs? Like, we could treat a whole bunch of people in provincial corrections, and then they're just going to continuously use if they don't have the right harm reduction supplies. So should we focus on a more of a prevention method and then have these services and then start treating people, or treat people and then try to fight for these services?
Sure, I'll start with, I neglected to say in my presentation that no provincial prison has any prison needle syringe exchange program currently in Canada. This is an area where I actually do think community, there is a massive role for community involvement to help stimulate that dialogue. And it's not rocket science. The two need to be done in tandem to eliminate hepatitis C. Treating without harm reduction or harm reduction without treatment, it's a package that goes hand in hand. Right now, there isn't a focus on that. And I think that the only way that we are going to get access to that in provincial prisons is to learn from federal corrections, because that's sort of been the role, or that's the way our provincial and territorial systems have learned from the success stories of federal and then have implemented it in provincial. So unfortunately, they've just been rolled out in the last year to two in federal, and it'll take some time, as everything does, to roll out in provincial. But if we can show success in federal, then I think we can convincingly argue that it's necessary. There's modeling studies to suggest that they both need to go hand in hand. So we have the evidence. We just also need to ensure that the prison staff know that it does not result in increased usage, and that there is no additional harm to the prison staff, which is the primary concern precluding the implementation and rollout of these programs currently.
And just on that, and I think it's so important because we come together, often and talk to people that agree with this, but like, what's being done to bring, provincial corrections people to these conversations so they can see these results and whatnot on a wider level, right? Like, we can talk to people that agree with it over and over, but we need to get the opposition to see it from a different lens.
I agree.
Can I just add? I mean, I totally agree with the need for a combination approach, but I would also say, let's not throw the baby out with the bathwater, right? There are concerns about reinfection. I think we should absolutely be providing individuals with harm reduction to help prevent reinfection, as well as other issues. But let's not use that as an excuse not to treat somebody, right? We have really good modeling evidence to indicate that despite high levels, even in settings with very high levels of reinfection, you could still have substantial population prevention benefits by treating people with ongoing risk. And some of the people that you treat, you will then, even if they're reinfected during that period, you will have prevented that chain of transmission. So I agree, with sort of pushing the message of combination prevention, but equally, if somebody's saying to you, look, we don't have harm reduction, they're just going to get reinfected, why should we even implement this treatment program? I think we have good evidence to indicate, no, let's move forward and then think about how we can build on that.
So we'll have a last question. Very quick question, very quick answer.
Lori Edmiston from Katie. This is more to let people in the audience know that Katie, along with PASAN and the Canadian Aboriginal AIDS Network, under the lead of the Canadian HIV/AIDS Legal Network, along with Canadian Aboriginal AIDS Network, PASAN, and under the lead of Canadian HIV/AIDS Legal Network, we are engaged in a court challenge with Correctional Services Canada to have needle syringe exchange programs. This has been going on for 7 years. We're back in court a week today. So they have started, but they've started very poorly, very slowly, and there's a lot of problems, which is why we are still engaged in the court challenge, even though they have taken some baby steps. So I think we've got a long way to go, including in the federal prisons.
Thank you.
Thank you very much. So thank you, Natasha.